Hello, everyone, and welcome. Before we get started today, just want to make sure that you can hear me clearly. If you could just, in the chat function, let me know where you're listening in from. As this is a national webinar, we're really hoping we can see lots of representation from across our country. So please let us know in the chat function. All right, we're going to get started here. Thank you so much for joining. If you're here to listen in on a national webinar on COVID-19, substance use, and safer supply, you've made it to the right place. I'd just like to recognize that this is co-collaborated with the BC Centre on Substance Use, Kapud, and London Intercommunity Health Centre. Before we get started today, I'd just like to take a moment to acknowledge the land on which we are calling in from today. So I would like to respectfully acknowledge the land on which we work is the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And it'd be worthwhile taking a pause for each of you and where you're situated today. I am doing my acknowledgement here in Vancouver, BC. Take a moment to think about where you're calling in from and the lands in which you're residing. Here's a quick overview of our agenda today. And so we have some amazing speakers for you, but you're going to hear some introductory remarks. We're going to go through BC's new safer supply guidelines. We're going to see an overview of a clinic in action. And then we're going to leave lots of time for some questions and discussion. And just a note on that, we will be taking the questions through the chat function. So as you're thinking of questions, as you're listening in to our speakers, please feel free to write them down, and then I'll be moderating that at the end. So I'm the one speaking here, and so this is Amanda Giesler from the BC Centre on Substance Use. And as I mentioned, I'll be your moderator for today. We have 4 incredible speakers on a deck for you, and I'm just going to do a quick introduction to them all as they have various substance use disorder expertise. So I'm going to start with Guy Felicella, and he's a passionate advocate for the vulnerable people who suffer an addiction. He spent nearly his entire life suffering from the same disease, and now he educates communities on harm reduction through public speaking to eliminate the stigma that exists around it. Guy is a peer clinical advisor with the BCCSU, has a career with the Vancouver Coastal Health and Ministry of Mental Health and Addictions. He attends various school districts as well to help educate students on addiction. We also have Matthew Bond, and he is the program coordinator for the Canadian Association of People Who Use Drugs, or Kaput. He's also a member of the Halifax Area Network of Drug Using People and the lead peer with Peers Assisting and Lending Support, outreach worker with Mainline Needle Exchange, and the national board with the Canadian Students for Sensible Drug Policy. He was an instrumental part in advocating and implementing the Atlantic Canada's first overdose prevention site. Then we'll have Cheyenne Johnson, who's an addiction-trained registered nurse and the co-interim executive director with the BCCSU. In her previous roles as Director of Clinical Activities and Development and the founding director of the Addiction Nursing Fellowship, Cheyenne oversaw the development of provincial clinical care guidance documents and dissemination, including evidence-based clinical guidelines, practice support tools, and policy briefs. She is also actively involved with the BCCSU's interdisciplinary program of research related to substance use. Last but certainly not least, we have Dr. Andrea Sarita. Dr. Sarita is a family physician with the London Intercommunity Health Centre, where she works with the Hydromorphone Emergency Safer Supply Substitution Program. She also works with the Street Level Women at Risk, a program in the community that uses a housing stability approach to assist women who are experiencing homelessness and involved in street level sex work. We're very glad to have this diverse group of panelists here with us today. And to kick us off, I'm going to leave it over to you, Guy, to kick us off with our introductory remarks.
Hi, everybody. It's a pleasure to actually be able to do this. I'm very passionate about advocating for not only harm reduction services, but also for safe supply. And that reason it impacted me in my life of addiction and substance use. For 20 years, I never overdosed once. And then in 2013, which was actually in the downtown area where fentanyl started creeping into the supply chain, I had to be brought back to life 6 times within 9 months. So the context is, for 20 years, I never really had to worry, too much. I knew how to use substances. And then in 2013, I just remember the panic and the fear that came over me because I had no idea of what I was getting anymore. And so the challenge for me was seeing people in 2016 and many friends. I've lost over hundreds of friends that are no longer with us on this earth today because of the contaminated drug supply. And I remember being diagnosed with opiate use disorder, and I thought it was such a relief. Finally, I'd be able to receive the help that I would need. And however, it turned out to be a curse. I was offered methadone and its rigid protocols with daily trips to the pharmacy and weekly visits to the doctors, plus, in fact, that it just didn't work for me, led me to struggle in active addiction. I remember asking for opioids and was classified as a drug seeker, and those medications, such as Dilaudid or morphine, were only for pain. I struggled my whole life with mental pain, and that impacted me physically. Well, today I can say in British Columbia that the curse of opiate use disorder has been lifted, giving people the ability to access a safer supply. These guidelines that you will learn about today are not extreme, they're just sensible. We are in unprecedented times, and we need options in order to deter people from buying contaminated street drugs, not only to protect people who use drugs from overdose, but also from contracting COVID-19. Withdrawal absolutely waits for no one, and COVID-19 will not deter people from what they have to do in order to not be sick. I would like to encourage all of you, doctors, to balance your clinical practice with a harm reduction balance. If you have a client who's on OAT and you still know that they are using street drugs, your client is not only at risk for overdose, but also for COVID-19. This not only puts your client at risk, but it also puts the public at risk. Offering a safe supply would give people the ability to practice physical distancing and end the relentless pursuit of getting and using to not be sick multiple times a day. Here in Vancouver, we have many different safe supply models that exist already. We have Dr. Christy Sutherland's eye out, tie out programs that are really beneficial for our people. And we also have the newest edition, which is the vending machine or lockbox, which is really a great option for people who are not able to present at a pharmacy or have a hard time making it and dealing with other individuals. I'm an option guy, and I believe that we need all options on the table. I am hopeful, and I believe that we all need to work together in order to get through both public health emergencies. After all, the slogan for COVID is "we're all in this together." So let's support people who use drugs instead of punishing them And I believe truly that we can do this right across Canada in every province. We're not just numbers that you hear, we're people that belong to families. We're your friends. Thanks for listening.
Over to you, Matt.
Thank you. Hi, everyone. My name is Matthew Bond, and I'm the program coordinator for the Canadian Association of People Who Use Drugs. And first, I just want to, thank the other panelists, Guy, Andrea, and Cheyenne, for helping put together this very important webinar on COVID-19, substance use and safer supply. And also, thank you to everyone joining us. The risk mitigation guidelines that are being discussed today need to be adapted and expanded across Canada to not only reduce the risk of infection of COVID, but to reduce the number of overdose deaths we see in our country, which is still at 11 deaths a day. And we're starting to see that number increase during COVID-19, and it will only get worse if we don't offer a safer alternative. Like Guy mentioned, we have some amazing harm reduction heroes that have been effectively offering these medications for quite some time with different models, such as Dr. Scott McDonald with Crosstown offering injectable opioid agonist therapy, Dr. Christy Sellerin offering multiple forms, including tablet injectable opioid agonist therapy, and Dr. Mark Tyndall and Dispensing Industries MySafe project, which is a contactless, secure automated kiosk that provides Dilaudid as a safe supply to fentanyl. Some may ask what a safe supply is, and Kaput has a concept document, and safe supply is defined as safe supply refers to a legal and regulated supply of drugs with the mind-body altering properties that traditionally have been accessible only through the illicit drug market. I'd like to highlight the word there, traditionally. We're now at a time where a safe supply of drugs should be offered as a first-line life-saving treatment. We have lost too many lives in Canada due to this, due to the overdose crisis, and with COVID ramping up, we have to do everything we can to not only protect ourselves, but the lives of some of the most marginalized and vulnerable citizens. Safe supply needs to be offered in the community, in the hospital, and in correctional settings. To provide adequate care to someone who uses illicit deadly narcotics, you need to provide them a safe supply. It not only builds trust with the patient, but it empowers them and gives them the autonomy to find meaningful employment, connect with their friends and family, and to live a responsible and productive life. In a little bit of my local context, out of Halifax, where I'm based out of, hydromorphine Dilaudid is still very much the opioid of choice. So if providers start to offer these safer medications, it will not only save the lives, but decrease the demand for an illicit black market fentanyl. Adapting prescribing practices used by the doctors that provide safe supply will allow us in Nova Scotia to proactively respond to the overdose crisis before we start to see numbers that we see in Ontario and BC of overdose deaths. And this has to be a long-term sustainable plan way past COVID-19. Advocates have been advocating for safe supply for quite some time, and this just can't be in response to COVID-19. This has to also be in response to the overdose crisis. I'll just wrap my little talk up here with, I like to say that harm reduction saved my life with access to safe using supplies, naloxone, and methadone, but I know a safe supply would have prevented me from overdosing multiple times, contracting hepatitis C, and ending up incarcerated with a criminal record. Can't the standards for people who use drugs be more than just not dying? We need as many doctors as possible to be prescribing safe supply, not just opioids, but stimulants, benzodiazepines, alcohol, and tobacco. This is not radical prescribing, it is sensible prescribing. So I'd like to just say and kind of ask, so people will think about it, will you prescribe safe supply? Save someone's life. Thank you.
Thank you so much. Over to you, Cheyenne.
Thanks, Amanda. And thank you so much, Matt and Guy, for sharing your stories, both personal.
Oh, sorry, Cheyenne, I think we lost you. Apologies, folks. We just had the audio cut out on our end. We'll just pause here for a couple seconds while we can reconnect with Cheyenne. While we wait for Cheyenne, Guy, I wonder if you want to speak to a little bit of the process of developing these guidelines in BC.
Yeah, for sure. The development, we've been actually working on these guidelines for last year, and then you know, the challenge with, you know, working with different struggles with different organizations such as Health Authority and then the pharmaceutical side of things, and everybody just in a pool. It just seemed like a big power struggle. And you know, it was kind of like playing the game of Zelda. You get through one level and then they say there's a level 2 to get to, and level 3 and level 4, and not knowing when the game's going to end. And then all of a sudden it became once the pandemic started to come around that we just started to push really hard here for things. And you know, one of the things that I know that me and Garth advocated for, because it was going to only be for people that were either positive for COVID or were waiting for a test for COVID. And I can remember us, you know, talking late into the evening about this, saying that it needed to be accessible for all people that struggled with substances, because everybody's at risk for COVID. And we actually said, if somebody has to get COVID to get safe supply, then people would get COVID to get safe supply. So it was one of those things that we really worked on, and it was so great to work with the different organizations of people from health and ministry and all levels of government and policymakers, and kind of see this collaboration come together, and especially with people with lived and living experience, which was amazing that everybody just started to realize that, you know, this is bigger than us, and we have to come together so that not only we can stop the risk of people dying of the contaminated drug supply, but also the risk of them having COVID. So it was brilliant how it all came together, and it was kind of like a whirlwind of 2 weeks, where long hours of working on them and reviewing and constantly reviewing and then reviewing again. And then finally, I just remember the day that it was announced, on the Thursday, I actually just went out in my backyard and paused, and tears were going down my face. And I'm even starting to get emotional now when I think about it, because I've been fighting for this for like 20 years, from back in the day when me and Dean Wilson were standing on the corner of Hastings and Columbia talking about, you know, this drug user pipe dream that we would be able to have access to safe supply in British Columbia. And, you know, I called so many people that I'd been fighting with for the last, you know, 10 years, and then thought of the people that were no longer here on the earth, and it made it more special. And now, you know, the work is continuing to make sure that this stays even after COVID leaves, because it's so important. And I'll even share with you something that I just received a call today from somebody in the downtown east side that's been on safe supply for 2 weeks, and he was talking to me about how his anxiety's improved and his mental health has improved and his overall health has improved, and he hasn't had to go out and do the daily grind that it takes to not be sick. And you know, it makes you feel good when you can impact somebody's life with something that it's so small, but it's so big for somebody, but we make it's so hard to receive for us. And so my mission is not only to, you know, make sure it stays in BC, but to bring this right across the country. And, you know, I know there's a tremendous amount of advocates right across from coast to coast, and I have a lot of respect for everybody, and just grateful that for all your work and hard work that you continue to do. And, you know, like Matt was saying, we just need some doctors to get on board. I don't believe that, you know, you have to look at the risks that it not only causes the individual, but also other people. And it's just a no-brainer that safe supply will change and improve somebody's quality of life. And so I'm just really excited. Is Cheyenne back?
I'm back. Can folks
okay,
hear?
Cheyenne, take it away.
Thank you for filling in for me, Guy. Maybe others are experiencing unstable internet connections while they're working from home as well. That's what I just experienced. So thank you for your patience. I was just saying thank you so much to Guy and Matt for your introductions, and also just want to acknowledge this webinar today was really their brainchild, and they brought all of the presenters together today here. In terms of my portion, I'm going to try to really zip through, but really what I wanted to just give you is a very high level overview of these risk mitigation guidelines that have been released here in BC, and focus much more on some of the implementation challenges and opportunities. So folks may have seen these guidelines. They came out a couple of weeks ago, and really to highlight, these guidelines are not meant to be substance use treatment. I'm going to talk a little bit about some of the guidance that we've developed here in BC, specifically for treatments like opioid agonist treatment, but they really are twofold, is to support folks who use drugs in vulnerable populations to self-isolate and maintain physical distance, to avoid contracting or spreading COVID-19. And the dual part of that is to also continue to address the ongoing public health emergency here in BC, but is also ravaging many parts of North America and all across Canada, to avoid substance-related harms from the toxic and adulterated drug supply. I just wanted to highlight, we will have an updated version that'll be posted on the website, and the link is there, and it's really just to give prescribers a bit more clear guidance, and we've developed some specific cases, fixed some typos, little things like that. So stay tuned for that coming up soon. I just wanted to acknowledge, we worked very closely, as Guy was giving a great overview of what sort of happened to bring all of this together. We worked very closely with many folks at Vancouver Coastal Health on a draft of a guideline that they've since published regionally, and now we have this provincial guideline. So it involves all of the folks that you see there, as well as many folks with lived and living experience of drug use within the Vancouver coastal region. As I mentioned, I wanted to touch really briefly on how these guidelines differ from opioid agonist treatment, or OAT guidance. So that's things like methadone or buprenorphine, naloxone, Suboxone. We've developed separate guidance for prescribers during COVID on how to support individuals and their families in managing carries, dosing, that should say, and delivery. Really looking at improving access to carries during COVID to, again, reduce transmission and support adherence for folks that are on those medications. And this really is substance use treatment. So this is really meant for individuals already engaged in substance use treatment for opioid addiction, or that are interested in engaging with opioid addiction treatment during COVID. Just a next slide, you're not really meant to read all of the different parts, and Guy touched on this, but generally when we develop clinical practice guidelines, it's a process that generally takes well over a year, brings together interdisciplinary experts, has this very rigorous approach. This is not what we did here. This was really interim guidance that was developed very rapidly, again, in the context of the overlapping and dual public health emergencies. However, the group that was involved in this, we really looked at both the literature as well as clinical and operational experience in a variety of programs, including things like injectable opioid agonist treatment that was mentioned, tablet injectable opioid agonist treatment programs, managed alcohol, nicotine replacement, and a lot of our work on safe supply to date at the BCCSU, including the Heroin Compassion Club white paper that we published last year, as well as our group's work with Health Canada in advising them around safer supply. For these guidelines, you can think about the eligibility as sort of a 1, 2, 3 to simplify it. The first eligibility criteria is really around people's risk for COVID. So they need to be at risk, have a confirmed case, or have a suspected case that is waiting confirmation. The 2 of that is they need to have a history of ongoing active substance use disorder. So, active substance use. It's important to note folks do not have to have a diagnosis of a substance use disorder to be eligible, and the substances used are listed there. The 3rd eligibility is really folks with a clinical assessment have demonstrated a high risk of withdrawal, at risk for overdose, cravings that would mean individuals would need to go out of their homes or places where they are sheltering in order to access substances, or other harms related to drug use, including transmission of infections like hepatitis C or HIV. I won't go over the next slide in too much detail because you can review the guidance, but at a very high level, the guidance provides guidance on providing medication for 4 kind of classifications of different drugs. So opioids using hydromorphone and mesylon, stimulants using dexedrine and methamphetamine or Ritalin, benzodiazepines considerations, and then also considerations for alcohol and tobacco, including nicotine replacement, managing alcohol withdrawal, and supporting relapse prevention. I'm going to go a little bit more in sort of detail around how prescribing works in a couple of later slides, but I think the key piece here in BC in terms of some implementation, the medication costs are all covered via pharmacare. We have indicated guidance for longer length of prescription, both to support isolation, sheltering in place, but also so we can evaluate these in the health systems, and utilizing existing structures that may fit in your region. Here in BC, we have something called a rapid access to consultative expertise line, and various supports like 811. The next slide just demonstrates that these guidelines are in alignment with the exemptions that Health Canada has recently enacted, which really permit 4 things. One is that pharmacists can extend existing prescriptions. They can transfer a prescription to a different pharmacy. They can take a verbal order from a prescriber to refill a prescription or extend. And they can permit a pharmacy employee or other allied health provider to deliver prescriptions of a controlled medication. So these exemptions really support the guidance in terms of its implementation and providing access to individuals. The guidance document also outlines, both for prescribers, what to discuss with your patient and what to document. I just wanted to provide a high level of this, but I believe Andrea is going to cover this in her part of the presentation. But it's quite important to talk to individuals about any changes to their treatment plans during COVID. Think about people's individual health needs, so other substances that they use, chronic conditions that they might have, other health, mental or physical health needs, consent, storing your medication if you're doing carries at home, if you lived with others or in shared living situations is important. Harm reduction is always key, and how people are going to pick up their medication from the pharmacy and the prescription length. Just go to the next slide. So getting into kind of the implementation challenges, I think as we've really been trying to work with regions and prescribers and others, I guess I'll preface that, this isn't perfect and we haven't figured it out yet. But kind of the ideal pathway that individuals would have to accessing safer supply here in BC following these guidelines would be people could contact their existing care provider. They work with that care provider to develop a care plan based on their individual needs. If safer supply and prescribing, pandemic prescribing was indicated, the prescription could be written and faxed to the pharmacy. The pharmacy would then fill that prescription and it could be either delivered or picked up by the patient. And then the patient would follow up with their GP or their NP sort of as needed via telemedicine, in-person check-ins, outreach team, and refills on those prescriptions could be managed by the pharmacy and the prescriber. The reality of what we're seeing, sorry, just back one slide, is there's many implementation challenges at almost every step in that potential ideal pathway. So you can see here instances where patients don't have primary care providers in their community. There's an unknown pathway to access. Prescribers might not feel comfortable in terms of their addiction medicine knowledge and be unwilling to prescribe safer supply. There might be other care plans to be developed around optimizing existing addiction treatment if that's applicable. And then there's a whole list of pharmacy challenges as well that are being worked through around unwillingness of pharmacies to prescribe, limited capacity for actually delivering medication. A broad concern Canada-wide and worldwide is the lack of personal protective equipment like gloves and masks for both pharmacists and patient safety. And also thinking about the variety of challenges in a country like Canada, and particularly in BC, where we have a lot of rural and remote communities for access for both to pharmacies and for prescribers. So some of the pieces that we're really turning our attention to and supporting stakeholders where we're able to is really trying to address and think through some of these system-wide and challenges. But I think for the group, thinking about national approaches to implementation, we really do not have a functioning addiction treatment system in BC and elsewhere in Canada. And that makes it just incredibly challenging to really scale up safer supply initiatives. And compounding that, we have a history of limited and poorly trained healthcare providers in the area of substance use and addiction. Myself, when I was in nursing school, I think I received probably 1 or 2 slides in a mental health course on addiction and felt incredibly underprepared before I received additional addiction training. As I mentioned, there's access issues in rural and remote areas across our province, and important to also note, controlled drugs and substances coming through as pharmaceutical alternatives to the legal drug supply have a specific supply chain, and we really need to pay attention to potential drug shortages or supply issues. I won't belabor them too much because we talked about a little bit of an overview, and this by no means covers all of the challenges in this area, but there are real and perceived challenges both on the pharmacy side, on the prescriber and the health system side, around sort of whose responsibility is safer supply in those systematic barriers that I mentioned, as well as some of the pharmacy components. to end off on my last slide for sort of a positive note, I think there really is an opportunity to really look at this opportunity and work with governments, both provincially and federally, around opportunities for a regulated drug supply and sensible drug policy. And a few pieces of that are Health Canada recently announced some new exemptions to the Controlled Drugs and Substances Act that look at supervised consumption sites, drug checking activities, municipal support, where we really could look at opportunities to scale up safer supply alongside existing harm reduction services like drug checking, supervised consumption, and overdose prevention. And I think the million-dollar question, and maybe the reason why lots of folks are here, is these guidelines really are meant to be interim for the overlapping and dual public health emergencies of COVID and the ongoing overdose crisis. And so through work that we're engaged in with the province, BC Centre on Disease Control and others, there's some forthcoming evaluation work that will really look to determine and leverage some of that evidence that we can apply to next steps. But I'll wrap it up there and turn it over to Dr. Sarita.
Hello, thank you for having me. Thanks, Cheyenne. So I'm Dr. Andrea Sarita, and I'm a family physician practicing in London, Ontario at the Intercommunity Health Centre in London. And in London, we've actually been operating a safe supply program for about 4.5 years for 120 people. So Cheyenne, she reviewed the recent guidelines with you, but it's going to be my job today to show you the nuts and bolts of a functioning safe supply program. So I'm going to talk to you about our protocol and our dosing and our results in implementing safe supply. And it's my hope you'll actually be able to build on that experience in London to operate your own safe supply programs in the safest and most supportive ways possible. I will at the very end of this presentation be providing a link to our guidance documents, so you can find out our more detailed protocol there, as well as our assessment documents and our teaching tools. Now, before we get into the meat of my presentation, I want to start by recognizing the peers and activists who have gotten us to this point with safe supply. For 30 years, people who use drugs have led harm reduction in Canada. And these activists, they took action to care for their own communities before the medical community or the government did. And I think it's really important to remember that as we move through this presentation, everything we now take for granted in harm reduction was once illegal and hard won by people who use drugs. So safe supply has been championed by people who use drugs for decades now. And these new safer supply guidelines from the BCCSU and my safe supply program in London, they really stand on the shoulders of drug users, both living and dead. So we've all been living with the consequences of the fentanyl-driven overdose crisis for years now. But with the introduction of COVID-19, we're experiencing a new intersecting threat for people who use drugs. This graph is from a modeling paper out of the University of California that was just published last week. And it shows an excess COVID mortality of 10 to 15% that is expected in people who are homeless compared to people who are housed. I know not every person who uses drugs is homeless, but I think many of the people we're all so worried about are homeless. And people living in homelessness have rates of chronic illness that are far in excess of people who are housed, and this puts them at increased risk of death from COVID. And when these baseline medical risks are combined with the need to interact with the street drug market multiple times per day, the risk of serious complications of COVID increases exponentially in people who are homeless and using drugs. So beyond the direct medical effects of COVID, we also know the street drug supply is becoming more volatile since the closure of our border with the US. Certainly in London, we're seeing an absolute lack of pills for sale on the street, and fentanyl is the only thing available right now, and the price of fentanyl has actually gone up 20 to 30% in the past week alone. People are feeling more desperate as it's harder to get drugs. And we also know overdoses are also up across the country. I know BC has seen a surge in overdose deaths in the past 2 weeks, and we're seeing that in Ontario as well. And whether that's due to the change in drugs that are available or a decrease in overdose prevention services is unclear. But I think what we do know is that there are going to be a lot of COVID collateral deaths that are going to happen. So how can we modify the risks of people who use drugs during this pandemic? We are demanding that every person in Canada has the right to self-isolate. And this means that we collectively need to provide all basic needs, such as housing, food security, income security, and a safe drug supply to those who need it. Right now, people who use drugs are really feeling the weight of inaction of government, public health, and physicians. And we want to change that narrative from they talk, we die to we act, they live. And over the next 15 minutes, I'm going to show you how we've been changing that narrative in London. So Safe Supply started in London after I observed the results of one of our in-hospital doctors. So this doctor manages the opioid withdrawal of people who use drugs when they're in the hospital using injectable hydromorphone. When people were done their hospital-based treatment, she would in many cases give people scripts for oral hydromorphone when they left the hospital. And Safe Supply started when I observed the positive health outcomes that were happening in these patients that this doctor discharged on these hydromorphone scripts. And what I would see is patients would do really well when they had these scripts. People would avoid overdose, they would avoid hospital admissions, they would attend clinic, and they would stop sex work or petty crime to pay for their street drugs. But when that script from the hospital doctor ran out, these people would turn to the street supply again, and we would start the cycle of intoxication, withdrawal, and illness that really defined their lives before entering hospital. So way back in 2016, I decided to continue prescribing hydromorphone for these patients after they left the hospital. I started with 3 patients who were really heavily street involved and who were almost constantly in hospital for complications of injection drug use, and these patients got better. After our initial successes with those first 3 patients, we began offering the intervention to more patients who we believe to be at imminent risk of death, both from contamination of the street supply, but also at risk of death from the ways that they were obtaining drugs and from health conditions that weren't managed because of the daily need to focus on seeking and obtaining drugs. We made the decision really early on that our focus is harm reduction and that the intervention would be firmly rooted in the voices of people who use drugs and developed with their guidance. Our program in London is embedded in a legacy of caring for structurally marginalized patients, and we offer wraparound harm reduction services and primary care to every single patient who's engaged with our Safer Supply program. So as I mentioned, the way we operate Safe Supply is different than traditional addiction medicine. Our goals are different and the way we interact with people is different. Typically, addiction treatment is about stopping using drugs, but Safe Supply acknowledges that people use drugs for very complex and personal reasons, and our goal is to help them be safer in their autonomous decision to continue using drugs. And we achieve this by offering drugs of known quantity, purity, and dose, but also by educating people about how to use in the safest way possible. So the drug we provide for our Safe Supply program is hydromorphone immediate release tablets, otherwise known as DILI-8s. And we made the decision to offer DILIs because of local research from London that showed that they had a much lower rate of infectious complications and disease transmission than other drugs such as hydromorphcontin. I've included references to this research on DILIs at the very end of this slide deck, and that'll all be available online afterwards. We also intensively educate our patients about safer injecting techniques, including the proper use of all injecting equipment, cooking all of their drugs, and how to be safe during and after an injection to prevent overdose. So again, I want to remind everyone that this protocol, as well as all the supporting documents, will be available at the end of this webinar through a link I'll provide. But over the past 4.5 years, we've developed a conservative approach to dose titration, seeking to suppress withdrawal and use of street drugs over a several-day initiation phase. The average starting dose that people require is 6 to 8 tablets of hydromorphone 8 milligrams. And we monitor patients really closely when they're being started on Safe Supply, and we see them daily for the first week or two and typically increase their dose by 2 to 4 tablets per day to a soft maximum of 16 tabs. And as I know everyone on this webinar has experienced, fentanyl has driven community opioid tolerances through the roof. So as fentanyl became the predominant drug in London, we also made the decision to offer people a Acadian backbone to their safe supply prescription in order to both provide relief from withdrawal, but also to limit the number of hydromorphone tablets that people need throughout the day. So currently we have a wide range of safe supply doses, with our average dose at 14 tabs and a median of 16 tabs. And then, like I said, we have about 1/3 of program participants who are using that Acadian backbone to supplement safe supply, and that median dose is 300 milligrams. We have 118 patients whom we've welcomed into safe supply over 4 years, and we have an exceptional retention rate at 90%. The vast majority of our safe supply patients receive a daily dispense prescription, such as in the BCCSU guidelines, but we do have a small cohort of patients who have up to a week of carries once they've shown evidence of stability in their substance use, health, and housing. So what do our patients look like at intake? All of our safe supply patients have been injecting drugs for a very long time, and all of them are exposed to the fentanyl contaminated street supply. 85% of our patients have had a trial of methadone or buprenorphine, and most have actually had multiple trials of these medications. And we really think that this speaks to the fact that with safe supply, we are trying to take care of a group of people who are treatment refractory to conventional addiction medicine therapies. So the characteristics of our patients and their outcomes, they need to be compared to people who continue to use the contaminated illicit street supply, and not compared to people who are able to be successful on methadone or Suboxone. And again, when we're talking about any safety concerns related to safe supply, we also need to be talking about the known mortality and morbidity of the street supply that's contaminated with fentanyl, carfentanil, and a grab bag of cutting agents. So our patients come from a very precariously housed demographic, with 62% being homeless on intake and 100% having a history of homelessness. And then on intake, almost half of our safe supply patients were engaging in sex work to pay for their street supply of drugs, and about half again were participating in petty crime like boosting or other forms of theft to pay for drugs. On intake, all of our patients were injecting opioids, and most were also injecting crystal meth. But the type of opioid people were injecting has certainly changed over the course of the program. In the first 2 years of safe supply, people were still predominantly injecting pills in London, which was mostly hydromorph content. But since 2018, this has dramatically shifted, and people brought onto the program from 2018 onwards are disproportionately buying fentanyl only. Our patients have suffered a lot of medical complications from their injection use, with 3/4 reporting ever having had an infectious complication. And we see significant rates of past endocarditis on intake and about average rates of Hep C. We have a large cohort of HIV positive patients who were either sporadically involved with treatment or not involved at all. And about half of our patients living with HIV, they weren't virally suppressed at the time of intake, and 3 actually had a CD4 of 0 when they joined us. So we'll get to results next. So our results are based on a comprehensive chart review of all safe supply patients from October of 2019. And the changes we have seen in how people use drugs and what they use is actually better than we hoped for. So again, remember, almost everyone in safe supply has failed standard addiction treatment, and everyone entered the program with an intent to keep on using injection drugs, albeit in a safer way. And yet, looking here, we have seen a reduction in injection drug use, with 1/4 of our patients choosing on their own to switch to oral use only, and then another 15% de-intensifying their use from IV only to a combination of IV and oral use. We've also seen a huge reduction in exposure to the fentanyl street supply. So remember, in London, the street supply is fentanyl, and yet we see only 30% of our patients being fentanyl positive in the past 30 days, and we believe this represents a huge reduction in their risk. And it's really important to note that during the worst public health crisis of our generation, we have had 0 overdose deaths in 4 years of program operation. We have had 3 deaths on safer supply with 2 deaths due to infectious complications of injection drug use, and I'm going to review both of those next. So both infectious deaths were in patients who, when they entered safe supply, were already at imminent risk of death. Before safe supply, both of these people had uncontrolled health conditions and both had frequent admissions for sepsis. But in both of these people, we saw improvement in these conditions while on safe supply. So although these 2 people did eventually succumb to complications of injection drug use, we do believe we made their lives healthier, safer, and longer with support of the program. And when we compare our mortality rates to documented mortality in people who use drugs but without an access to safe supply, you'll see our mortality rates are less. So this study here, it looked at all-cause mortality in people who inject drugs in Vancouver, and it found there was a 3% annual mortality in injection drug users who did not access safe injection facilities, and a 1.7 mortality rate in those who did. So safe supply patients are not regular injection site users here in London, and that's for a lot of complicated reasons. But that means our all-cause mortality can be compared to the 3% rate. So although we're early in our data collection and analysis, our early results are really encouraging in that we're seeing a trend significantly less than expected mortality rates in our high-risk group. And although we've had 2 deaths due to infectious complications, we have seen a huge improvement in the management of other infections and in the treatment success of our patients living with HIV. So we've reduced our amount of HIV viremia from 47% of patients being positive at intake down to 10%. And we've also seen a really good uptick in people who are getting treatment for their Hep C, with a quarter of safe supply patients engaged somewhere on the spectrum of Hep C treatment. We have had 5 patients with epidural abscess in 4 years of program operation. All of these patients who developed epidural abscess were either adding long-acting preps of opioids or illicit fentanyl from the street supply to their safer supply. We've had no epidural abscesses in patients who were confirmed by urine toxicology to be only using their safe supply prescription. And the epidural abscesses we're seeing in our program, they're on a background of a provincial increase in epidural abscess in people who inject fentanyl. So the investigation of this is in its early days. We don't know exactly how our rate of epidural abscess compares to the rest of the province, but this is something we're actively monitoring. We do know, back one slide, thanks, almost done. We do know that we have dramatically reduced the rate of endocarditis in our group compared to usual rates, because if you recall, we had an intake rate of 26% for endocarditis, but in 4 years, we have had 0 new cases of endocarditis and only 1 case of recurrent endo, which is dramatically less than the 30% recurrence rate typical in this population. So this is not a sexy slide, but this is some of the work we are most proud of. We have seen an absolutely profound change in how our patients access care. We think that besides all of the work we've done to reduce morbidity and mortality in this group, one of the most profound things we've achieved is bringing a group of people back into healthcare who were previously almost completely excluded due to stigma and structural violence. And it's really hard to capture the joy we feel in seeing this happen. Beyond health outcomes, we're seeing improvements at a systems level. We've reduced homelessness by about half in the group, and we've also decreased the number of women in the program who are performing survival sex work from 68% down to 20%. And then we've seen the self-reported rate of illegal activities to pay for drugs reduced from 48 to 12%. There should be a link to the guidance document. Is that the next one? Oh. So I did have a link in there, and I think it'll be posted on the recording on the BCCSU website later. But we do have a link to our guidance document that I said also includes all of our assessment documents and teaching tools. So I'm sure that's going to be up on the web sooner than later, and we invite you all to take a look at that. So thanks for having me, and I'll turn the mic back over to our moderator for some questions.
Thank you so much, Andrea. So now if you can list your questions in our question function in the chat there, We'll take a couple, and we're going to try to do this in a rapid fire style, just given we've only got about 5 minutes left to do this. So the first question for our panelists is, what happens beyond COVID-19? What does safer supply look like after our pandemic?
What does safe supply look like after our pandemic?
Yes.
Well, I can tell you this, that we're definitely going to fight to continue it. That's for sure. I don't have a crystal ball or know the future, but I do know this, that as a person with lived experience who fights for safe supply, it won't be something that, we'll be able to go back, as as long as there's a contaminated drug supply, then we're going to need a safer alternative. And this is just something that will, and I'm confident that it will continue.
And I'd like to.
I was going to say, I think COVID is forcing the country to look at drug users as human beings and look at what they actually need for their own health and well-being and to survive this pandemic. I'm sorry that it came to, a worldwide pandemic for this to be noticed by everyone, but I'm hopeful through this we're going to generate the evidence that this can help a lot of people.
And I'd like to just piggyback off of Guy and Andrea there. I think what safe supply looks like after the pandemic is up to the providers and the prescribers. You just witnessed the amazing results from Andrea's program, and I think as prescribers, you can implement these safe supply programs in your local community. So I think it's really up to them to provide it.
Dr. Sarita, a question for you. What was the biggest hurdle to implementing the London Safe Supply program?
I think it was in gaining community trust. Obviously, Guy has referred to this as, it's considered radical, but it's really quite sensible. So I think with the first few patients, people are like, I don't know what we're doing here. But as we began to demonstrate the results, and people who would see our patients every day, so frontline outreach workers, the nurses, our pharmacists, our pharmacy technicians, they were able to see day by day how quickly people got better. And so I think, although kind of community questioned us in the beginning, they were very quickly able to see the results.
Great. There was a question about, again, sorry, Dr. Sarita, for you. Are you offering oat with safe supply? Are you offering both simultaneously?
So we offer KBN, as I alluded to. We also offer conversion to Suboxone or supplementation with Suboxone for anyone who wants it. We don't provide on-site methadone, but we do have referrals to clinic and then other providers if people are interested.
And in BC, you can be on a combination of OAT and safe supply as well.
The reality of it is that the majority of our patients have had really negative experiences with the traditional OAT system. So usually by the time they get to us, it's just simply something they're not seeking anymore.
Okay, a question for the group. Can you clarify how safe supply would be provided to someone who is homeless under the BC guidance?
Well, they can get a prescription. There's many ways that they could do it. This could be a great tool for possibly even the vending machine to store their drugs in the machine, and then they would just go to the machine daily. It's authorized by a hand scan, so but it won't deter whether you're homeless or have a house. If you're an active substance user, you're at risk for overdose death and COVID-19 transmission, so you qualify for a safe supply.
Yeah, Cheyenne here. I'd just add to that by saying, you know, obviously clinicians would look at people's individual social supports networks, including housing. And so for folks that are unstably housed or are homeless, there might be considerations if they aren't symptomatic or have been in contact with people with COVID recently, that you could just encourage and improve connection to the pharmacy, in addition to looking at what carry schedules could be accommodated, and safe storage of that, as well as working with maybe shelters or other community organizations to look at opportunities for safe housing for an individual like that during COVID.
Thanks, Cheyenne. So recognizing we are now at 1 o'clock here on the Pacific side, we're going to be closing this webinar now. Just a huge thank to our amazing speakers today, Cheyenne, Andrea, Matt, and Guy. It was such a delight to have you. To the group, we'll be circulating a recording to this, so if you didn't get to tune into the whole thing or you want to share with colleagues, please go ahead. We'll also be sending around a PDF of these slides, and it'll be all available on our website so that you can have access to all of these great links and guidance documents. A big thanks from us at the BCCSU, and have a great rest of your day.